Thank you for inviting me here. So I will be presenting the 5-year update of CROWN data. And so we all know that CROWN is a landmark trial in ALK-positive non-small cell lung cancer patients. Stage 3B and stage 4 patients were enrolled. This is the original study design. And please note that asymptomatic treated or untreated CNS metastasis patients were allowed to be enrolled. So they were randomized into Lorlatinib 100 mg once daily, that is a standard dose, versus Crizotinib into 250 mg standard dose BD, randomized into 1:1 fashion. And the primary endpoint of CROWN trial was PFS by blinded independent central review. And the secondary endpoints were PFS by investigator, objective response rate, intracranial response, and OS. So these are the baseline characteristics. Please note that 26% of the CROWN trial patients had brain metastasis. So this was the original result, got published in 2020 in NEGM. They showed that the PFS was significantly, not only better, in fact it was double. 1 year PFS rate in Crizotinib was only 39% versus 78% in Lorlatinib arm. And PFS by investigator assessment was also significant. And so now I will be presenting the 5 years follow-up data. This is a post-hoc analysis reported, updated investigator assessed efficacy outcome, safety, and some biomarker analysis result. The median follow-up for PFS in Lorlatinib group was 60 months, and in Crizotinib group it was 55 months. So this is the CROWN PFS data after 5 years follow-up. Look at the separation of curve. Such separation of curve we usually don't see. The hazard ratio is jaw-dropping. It is 0.19. The PFS, median PFS was not reached in favor of Lorlatinib versus only 9.1 months in favor of Crizotinib. At 5 years, 60% patients were alive and progression-free in Lorlatinib arm versus only 8% in Crizotinib arm. So PFS by two subgroups, whether they had brain metastasis or without brain metastasis. In patients who did not have any brain metastasis at the time of enrollment, the hazard ratio was 0.24. The 5 years PFS rate was 63% in Lorlatinib group. Patients who had brain metastasis upfront, even in those patients, the hazard ratio for PFS was 0.08, magnificent hazard ratio. And even in brain mets patients, the 5 years PFS rate and Lorlatinib arm were 53%. And actually, it could not be calculated in Crizotinib because almost all patients, they progressed in CNS within 2 years. What about the response rate? 81% patients in Lorlatinib had partial response, objective response, and Crizotinib arm 63%. 10% patient in Lorlatinib arm had complete response, and only 2% in Crizotinib. The duration of response was also prolonged. That response not only higher in number in Lorlatinib, but it was durable, not reached in Lorlatinib versus only 9.2 months duration of response in Crizotinib. What about the intracranial response rate? Confirmed intracranial objective response rate was as high as 60% in Lorlatinib arm versus only 11% in Crizotinib arm. And most of these intracranial response were complete response. Look at the figure, 49% patients in Lorlatinib arm, they had intracranial complete response. If we look at the data of complete intracranial response who had measurable brain mets, then the percentage was 58%. If you compare the other competitor molecule for Alectinib, in ALEX trial, it was only 38%. So time to intracranial progression, not only the response rate was higher in intracranial, it was durable as well. So the median time to intracranial progression not reached in Lorlatinib versus only 16.4 months in Crizotinib. And again, once again, please note the hazard ratio, it is jaw-dropping, 0.06. So Lorlatinib delayed intracranial progression versus Crizotinib, and there was no intracranial progression events after 36 months. So these are the intracranial progression in patients who had brain mets and who did not have brain mets. Without brain metastasis, the hazard ratio for intracranial progression was 0.05. The patients who did not have any brain metastasis, in that arm, only 4 patients in Lorlatinib group patients, they developed brain metastasis. And the patients who had brain metastasis upfront, there also the hazard ratio for PFS was 0.03. Such kind of PFS we don't see any clinical trial. So what about the efficacy of Lorlatinib in other important subgroup? We all know that EML4 ALK version 3, that is a poor prognostic version. So in that group also, 60 months was the 5 years PFS was 60 months. And so that proves that across all the subgroups, Lorlatinib was efficient, superior. Even in the presence of T53 mutation, the median PFS was 51.6 months. So the patients, all the patients' blood sample was collected for circulating tumor DNA, and there was no new ALK mutation on-target resistance mutations were noted. So that means that Lorlatinib has a broader activity coverage over multiple secondary resistance mechanism on-target ALK mutations. The most of the mutations in Lorlatinib was because of off-target activation of different pathways. What about adverse events? My next speaker, Dr. Mridul Malhotra, he will be talking on adverse events in detail. But adverse events related to treatment discontinuation was only 5% in Lorlatinib arm. So most of the adverse events, they did not require discontinuation of drug. Supportive medicines, modification of dose actually solved most of the problem. The major grade 3-4 adverse events in Lorlatinib arm were hypercholesterolemia, triglyceride, and rise in cholesterol, and hypertension and weight gain. So as you notice that cognitive effect, which all the medical oncologists are also concerned, most of the cognitive effect impairments were grade 1 and grade 2. Hardly you will see any grade 3 or grade 4 cognitive effects. So the 5-year safety summary is that safety summary is consistent with the primary analysis, no new safety signal, and only 5% patients they discontinue Lorlatinib due to treatment-related adverse events. And so, and if you modify the dose of Lorlatinib within 16 weeks, the first 4 months, how they are doing, even in such situations, actually it does not impact the final outcome. You'll see the curves are not separating widely. So in such dose modified Lorlatinib patients are also doing well. So to summarize, 60% of patients were alive after 5 years. This is magnificent improvement, and such improvement is not seen in any molecular targeted therapy, not only non-small cell lung cancer, it is even in across all other solid tumors. 92% of patients remain protected from CNS progression with a hazard ratio of 0.06, and the safety profile was consistent with the preliminary result. Thank you, everyone.